From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Welcome to the JAMA Psychiatry Author Interview podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Risk of Schizophrenia Spectrum Disorder in Individuals with Emergency Department Visits Involving Hallucinogen Use. We're about to talk to the first and corresponding author of the paper, Dr. Daniel Myran, MD, from the Ottawa Hospital Research Institute in Ottawa, Ontario, Canada. Today, in many states and regions across the world, there's more interest and access to hallucinogens. One common one we have heard of before, say, is psilocybin. There's many more we'll discuss in this podcast. While there's research and hope that some of these hallucinogens could be used to treat mental disorders like depression, many of them still are illicit substances, and we're learning about what are the risks and side effects and potential harms. We've already known that there's an association between hallucinogen use and schizophrenia spectrum disorders, but what exactly is that risk, and how does it, say, impact people in the general population that currently don't have a mental illness? To answer this question and really get the best detail on potential harms and risks, we're going to talk about the results of a brand new paper just out in JAMA Psychiatry. So thank you so much for joining us, Dr. Myran. And to get started, what exactly are hallucinogens? Is cannabis one of them? Is it not one of them? Let's lay the ground straight here.
Well, thanks for having me on the podcast, Dr. Torous. So hallucinogens are drugs or substances that, in essence, change the way you perceive the world. And at the senses, right? So visual, smell, taste, sight, hearing. And what happens is that taken at a sufficient dose, they cause distortions with realities. They cause sufficient perceptual changes that people can no longer tell what's real or not and would then begin to hallucinate. And you mentioned one, so psilocybin. So when we're talking about them, so like psilocybin, LSD, MDMA, or ecstasy, these are a lot of the drugs that we're hearing about.
So classically not cannabis then?
Yeah, so it's interesting. So cannabis can cause hallucinations. And some people consider it a hallucinogen and other people don't. Most right now in kind of contemporary research and considerations, it's not considered usually a hallucinogen. And in this study, we don't consider it a hallucinogen, and we'll actually compare hallucinogens to cannabis.
Got it. And how common is hallucinogen use, and what are the trends in use?
The trends are super interesting. So hallucinogens were relatively stable in the United States until around 2014, 2015, when they start increasing. So surveys that are asking about past year hallucinogen use in the US, around 9% of 18 to 30-year-olds have used it in 2000.
Pretty high.
Very high, and that's double what use was even 10 years ago.
Wow. So we've known in the past that there is some link between these hallucinogens and schizophrenia spectrum disorders. Oftentimes, again, the newest studies, say, of psilocybin were excluding people with these disorders. So what did we really know from the prior research and before you and the team did this study about what was the potential link between hallucinogens and schizophrenia spectrum disorders?
So I was quite surprised actually at the onset of this of how little evidence we had on this topic. And I think that you could look at it through three different domains. And there's a number of case reports where certainly people who use hallucinogens can have an immediate hallucinogen-induced psychosis. And that's where someone can have psychotic features. They often present to the emergency room. And there's also case reports of persisting symptoms of psychosis after hallucinogen use. So the person is no longer intoxicated from a hallucinogen, but they're having ongoing symptoms. And similarly, kind of what are sometimes called flashbacks, or someone who used hallucinogens, they have not recently used them, and then they might begin to hallucinate or have psychotic features again. And then within that, you then have, as you were talking about, clinical trials. And there's been a number of clinical trials. And so far, one of the safety signals has not been that people are developing psychotic features or schizophrenia in them. Now, we have to keep in mind that there's only been hundreds of people in clinical trials, and schizophrenia is a relatively rare diagnosis, and they're not observed that long. So it's not really something that you would expect to see in clinical trials, especially since they're excluding high-risk folks, people who have a family history of schizophrenia or have actual schizophrenia.
So we have this interesting case report evidence, as you said, a little bit of prior studies saying different things could be happening. We don't have large samples, prospective samples, good cohorts of it. So clearly you and the team set out to address this. Can you kind of say what was the goal or theme of your study?
So we took an alternative track. We're using big data or health administrative data. In Ontario, where the study sat, which is the most populous province in Canada, we leverage the idea that we have a universal health system and that we can follow everyone in the province for their healthcare visits over time. And we were interested in saying, well, look, what happens to individuals who show up in the emergency room with hallucinogens? So it's the reason that they're there, or one of the reasons that they're in the ER, is because of hallucinogens. And let's see if they are at risk or if they develop schizophrenia after their visit. And we'll compare them to people in the general population, which is people who didn't have a hallucinogen visit.
And I think you kind of hinted at these methods, and you're going to be able to get a lot of people by using emergency department records. What was your sample and who were you collecting it from? And maybe what was the date range that this was done?
So we ran our study between 2008 and 2021, and it's for all of Ontario. So we have a population of over 14 million people. Specific to our study, we look at people aged 14 to 65. And it's everyone who lives in the province during those time periods who's eligible for our health system. That's 97% of the people living in Ontario.
So 97% of 14 million is a very big number that you have access to. And considering, again, this is a study of data from Canada, is there anything that listeners need to be aware about regulations for hallucinogens or Canada, or special rules that may influence rates of use or not use?
So hallucinogens in Canada and in Ontario during our study timeframe are illegal under the Controlled Drugs and Substance Act. There are two pathways where people can get access to hallucinogens. One is in clinical trials that get exempted from the CDSA. The other one is that very recently, actually after our study finished, healthcare providers can apply through a special access program where they write to Health Canada, who's regulating it, and they say, look, I have a patient, I think they would benefit from hallucinogen-assisted therapy or psychedelic-assisted therapy. Can you please grant access to it? And that has just started and is quite limited. So there are pathways, but for the intents and purposes of this study, essentially everyone who's showing up in Emerge with an ED visit involving hallucinogens has acquired it through a non-legal channel.
And as you said in introduction, there's close to 10% of people may have tried them. So definitely these seem to be accessible to people. Returning to the study and what you did, your primary outcome was the development of a schizophrenia spectrum disorder. Can you review the exposures you identified from the data as well as covariates in trying to figure out who comes to the ED, again, because they had a hallucinogen, is going to go on to develop schizophrenia? But let's go into detail on those data and what you're collecting.
So we find everyone in the study who has a first-time visit involving hallucinogens. And that's identified through diagnostic coding. And it's based off of the clinical judgment of the treating team, where they kind of say, oh, we think that hallucinogens were the main reason or a contributing reason for these visits. We then subdivided hallucinogens into hallucinogens with and without psychotic features. So you have someone who's in Emerge and they have a hallucinogen-induced psychosis, and they're having psychotic symptoms at the time of their visit. And then everyone else who's there, and they might be hallucinating, but they are not having psychotic features. One of the limitations that we have is that there's a huge study. We capture all the emergency room visits, but there's no codes specific for different types of hallucinogens. So other than LSD, for which there's a poisoning code, I can't tell you what proportion of these are from psilocybin or from MDMA or from other types of hallucinogens.
That's an interesting point. In your study, you included 9,244,292 individuals without a history of substance-induced psychosis or schizophrenia spectrum disorders, and they were followed for a median of 5.1 years in the study. How many of these had emergency department visits involving hallucinogen use, and can you share any details about these people that were perhaps of most interest in the study?
They're super rare. We have just over 5,000 people with no history of psychosis who show up and they have a first-time hallucinogen visit. And again, much rarer than other types of substances that we'll talk about. It's not a common presentation. They skew heavily male. So I think they're 70% male. They're quite young. They're on average 27 years old. And unsurprisingly, they have a very high degree of comorbid mental health and substance use care. So, for example, a quarter of them in the past year have been in emerge because of alcohol. 36% of them have seen a psychiatrist in the past 5 years. So they are very different in many ways from the general population, in that they have a much higher degree of comorbid mental health and substance concerns.
And from using the records to identify when these people came to the emergency department, did you notice trends in certain years? Is it decreasing? Is it increasing? What's happening over time?
Our study starts in 2008 and runs to 2021. So between 2008 and 2012, 2013, the visits are actually quite stable. And then between 2013 and 2021, they go up by over 80%. So there's really a rapid increase in them. We know this is around the period that people are starting to use more hallucinogens. And we also know that if you speculate, it's around the time too that there's beginning to be a lot of buzz and discussion and societal interest in it. So probably as people use it increasingly, they experience more harms and show up and emerge.
Certainly a logical conclusion is we know it's hard to answer that question definitively, but that makes sense to me. Let's talk about perhaps the main outcome of your paper, the risk of developing a schizophrenia spectrum disorder in people who came to emergency department with a hallucinogen use. Can you take us through your main result and notable aspects of them that are important for all of us listening to understand?
For sure. And I'm going to talk about some absolute numbers, and then we'll talk about some relative rates. And I think both are important. So within 3 years of having an emergency room visit involving hallucinogens, 3.9% of people who have a hallucinogen visit will actually be diagnosed with a schizophrenia spectrum disorder. And that is 21 times the risk in the general population of people of the same age and sex, who it's 0.1%. And we subdivided between hallucinogen-induced psychosis and hallucinogens without psychosis. And we find that the hallucinogen-induced psychosis group, they're at much, much higher risk. They're at 20% schizophrenia within 3 years. Really, really high rates.
Yeah. As we alluded to in the introduction, we could kind of compare these rates to, say, people who come to an emergency department using other substances like cannabis or alcohol. So what were your results around those?
These are actually, for me, some of the more surprising results of the study. We had previously done a study looking at rates following cannabis and alcohol and amphetamines and some other drugs. But what we saw in this study was that the individuals who have a hallucinogen-involved ED visit are actually at higher risk, 1.5 times the risk of someone who has a cannabis-involved ED visit, and almost 5 times the risk of someone who has an alcohol-involved ED visit. And to me, that's concerning and interesting because cannabis is really considered the riskiest substance in terms of associations between its use and schizophrenia.
Exactly. It's been a large issue, I think, of cautioning people away from using cannabis, especially as it becomes legal or recreational in states. But here you're saying we may have substances, hallucinogens, that confer much greater risk.
That's certainly the association that we're seeing in the study. And I think that as we look at that, it really is important to consider cannabis is still much more common. And even in our study, if you look at the absolute number of cannabis or hallucinogen visits, there's more than 10 times the number of cannabis visits. So if you think of this from a population perspective or a public health perspective, a much more common potential risk factor that's maybe slightly less risky still can cause more harm for everyone. But I do think that we should not negate the strength of the association that we're seeing here, especially as hallucinogens and hallucinogen-involved ED visits are rapidly increasing.
And I think I pulled from your paper, you said the results show at least a 3.5 times elevated risk, even accounting for socioeconomic status and other comorbid mental health disorders people may have who came in with hallucinogen use. So even if we consider a 3.5 elevated risk, how would we want policymakers to think about these results in this era where, again, there's more interest in hallucinogens, there's efforts to legalize them, and here we have this new result that could be potentially concerning?
I think it's such a great question. And I think that there's clinical implications and there's policy implications. And starting on the policy side, there are 2 distinct policy questions that are happening. One of them is about legalization, and the other one is related to the regulation and approval of this as a medical treatment. And I think we have to absolutely separate these two ideas. I think that if we want to have a societal conversation about whether or not we should legalize non-medical or recreational use of hallucinogens, that is a distinct conversation. And we can talk about it. Does it make sense to have criminal offenses for people who are having possession or use of these substances? It's, again, not as common as cannabis, so maybe the criminal justice reform argument is less relevant, but that is a thing. Or are we saying from an individual right, should people have the right? Should this be something that adults can choose to do? That is a conversation. That is a fine conversation. But we need to divorce it from the conversations that are also relevant about potential medical benefits and risks, about who provides, how that's regulated. And I worry that if you blur those two things, there's a real risk to some of the benefits that can be achieved through the medical side.
That's a very good argument that we have to separate out, as you said, the legalization from the regulation. And I think what's so exciting about your results is it gives us numbers to talk about. We actually have things to say, here's what could be happening, here's the risk. These are more authoritative numbers, when before, as you said, we kind of had case reports, we had suggestions, we had weaker evidence, but now you're bringing data that can be useful for both of these policy angles. And I think clearly on the clinical side, I don't know many clinicians personally recommending these at all. I think I would say I know none personally. But for clinicians listening to this podcast, hopefully reading more of the great details that you and the team have in the paper, what would you want them to be advising or discussing or perhaps warning patients about?
I think that from a clinical perspective, this is a new group of drugs and it's a new therapy. I really do see, based on the evidence so far, much of which is promising. In the future, I think that there will be psychedelic-assisted therapy, which will be an evidence-based treatment for some mental health conditions. I think that we have to take a step back and say this is so early. It's really in its infancy. Again, the number of people who've actually been in these trials is super low, and that there has been immense hype about the potential benefits, and that we know very little still about some of the risks. And I think with that framing in mind, I think that the conversations between clinicians and patients begins with talking to patients who we know should probably not be using these. And I would say that that absolutely continues to be people who personally have had psychosis or a diagnosis of a schizophrenia spectrum disorder or have a close family history of that. This is not a causal study that we did. There are huge, huge remaining questions. I think this is from a precautionary approach, that this is an at-risk group. Use in that group, I think it comes with risks.
I think you and the team have done a very nice job outlining the risks at a very large scale in a way that has not been done in the literature. So the paper is there for people to read. So I encourage everyone to look at the details of this fantastic work. Again, I'm Dr. John Torous, and I've been speaking with Dr. Myran about risk of schizophrenia spectrum disorder in individuals of emergency visits involving hallucinogen use. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thank you for listening.